Hi everyone, welcome back to our journal club. We are getting like pretty close to, I don't know, maybe 2/3 of the way through all the journal club articles. Tonight we are going to be live. We are live, and let me see if I can just add on our guest speaker, who you may remember from Monday. Okay, sent her an invitation. So Dr. Sekhon is going to be doing our article tonight. So, hi, is that Ina or Ina? My sister's name is Irene, which is kind of like that. Okay. Yeah, and anybody who's watching, feel free to say hi. In the meantime, hi Zubi, how are you? Yeah, I don't know if people are getting, I had a request earlier today from one of our previous speakers, actually was asking me if I was interested in doing the, hi Bushra, if I was interested in doing the child and adolescent psychiatry articles. And I was just saying that I have considered it. I feel a little bit busy with my time, and we'll be looking forward to when this series of articles is done. Hi, can you join us, Gundeep? I sent you. Oh, you did. Okay. You sent an invitation. Okay. But I was saying, I'm not 100% sure how useful these videos are for people. I think so. Hi, how are you?
Hello, doing well.
I was just kind of chatting by myself.
I heard you.
Oh,
I
you
was
did?
watching.
Okay. Yeah, no, so I was just saying I feel like theoretically like these videos should be helpful for people, but I don't know how helpful they actually are because I've been following some of the posts on the articles like through ABPN, and they don't sound like they're that hard. It sounds like some of the questions may be flawed and they're kind of fixing that as it comes up, but yeah, I don't mind doing these videos. I think it's kind of fun. I think it's interesting, and I think I was excited to put this series together just to see if we could do it, and just to I've never like heard of a journal club series for CME on Facebook, so that's why I wanted to do it. Like secondary thing was like, oh, hopefully it'll be helpful for people. But yeah, so if you guys do find the videos helpful, please let us know. And we could consider doing the child and adolescent articles. I'm not convinced right now that we should do them. So, but I'm willing to listen
I've read
to
some
people's
positive.
voices.
I've read some positive reviews where on the ABPN project group,
Mm-hmm.
they're saying that one way to do it is to print the questions, watch these videos, and then do the questions.
Oh, okay. Well,
So
that's good. That would be good.
yeah,
I feel like I haven't gotten this much CME in like years, so because I'm listening to every single one, obviously,
you have
but
to.
yeah. Okay. Hi, Laura. So Laura also was having trouble getting on. I'm glad you made it on. Okay. Well, welcome back. This is Dr. Sekhon. She is presenting our article tonight. Just as a reminder, she is a psychiatrist in California, working in the California correctional system, which is really cool. And she is a geriatric psychiatrist, so by training.
All right.
Welcome.
I saw one of my fellow residents watching Marie Rose. So hi, Marie. All right,
Yeah.
so let's see. So today's article is the Aerobic exercise for Alzheimer's disease, a randomized controlled pilot trial. This was published in 2017. And as the name suggests, they wanted to see the effects of aerobic exercise for patients with Alzheimer's disease. So talking about numbers, the numbers here in the article are a tad bit dated. The current census is 5.7 million Americans have Alzheimer's dementia.
Mm-hmm.
And it will more than double by the mid-century. It will go up to 14 million. Those were the figures that came out from Alzheimer's Association 2018 facts and figures. So we have had data suggesting that exercise may decrease neuropathological burden and increase hippocampal neurogenesis. And this was proved in the animal research. In the humans, we have had observational evidence saying that it leads to greater brain volume, less brain atrophy, slower dementia progression, and a decreased risk of dementia. There are some studies also suggesting that it might attenuate the detrimental effects of the amyloid, cerebral amyloid on cognition. There was another study where it was home-based exercise as well as counseling, and it benefited in terms of physical function and depression compared to usual care. They didn't have MOX therapy, so that showed. So there have been, more and more studies suggesting that exercise or physical activity is helpful in terms of cognitive decline. The objective of this was a pilot study. It came out of University of Kansas. Their aim was, the hypothesis was that cognition, functionability, and depression would benefit from aerobic exercise, and they wanted to compare it with strengthening and toning exercises. And if you go to Health and Human Services website, the President's Council on Sports, Nutrition, and Fitness specify that every American adult should have 150 minutes of moderate aerobic exercise per week or 75 minutes of intense aerobic exercise. So they were following the public guidelines of 150 minutes of moderate aerobic exercise. This trial was called Alzheimer's Disease Exercise Program Trial, ADEPT. And basically this was a 6-month long trial. It was 26 weeks. They recruited patients through from August 2010 to September 2014. The follow-up testing was completed by April 2015. And this was University of Kansas along with 16 YMCA facilities. The participants had to be at least 55 years old. They had to have a diagnosis of MCI or dementia with a diagnosis of probable Alzheimer's disease. The rating on CDR or clinical dementia rating had to be very mild or mild dementia. And they did a telephonic interview on the first screening, and they wanted the lifestyle to be sedentary. They had to have a caregiver who would accompany them to all these sessions. They were living in the community, didn't have any physical issues that would come in the way of these exercises, and stable on the medication for the last 30 days, and would be able to participate in the evaluations as well. In terms of exclusion criteria, if there was a significant psychiatric disorder that was exclusionary, any illness that would be a safety issue, if you had a clinically evident stroke, you had cancer in the last 5 years, MI or CAT in the last 2 years, alcohol abuse or drug abuse in the last 2 years, insulin-dependent diabetes, or any significant pain issues, that would exclude you. And this was important because they had a companion study going on, and they were recruiting along with this study where patients had the same demographics except for the cognitive decline. They had the same inclusion and exclusion criteria except for the diagnosis of Alzheimer's disease. And they were standardizing their scores along with, so that was very important. And the sample size, the goal was to get 80 patients. However, after screening almost 250 patients, they were able to get 76 patients, and they were divided into 2 groups, the stretching and toning group, which had 37 patients, and then the aerobic exercise, which had 39. 68 completed the study, so not as much of a dropout, but still there. They had an independent safety committee that was reviewing the adverse outcomes quarterly, and a clinician was constantly checking about adverse outcomes. In terms of outcome measures, they wanted to check for memory, and the memory composite scores logical memory, including immediate and delayed, free and queued selective reminding test, a sum of free recall Boston naming test was included. However, they did take the Boston naming test data out because of some uncertain psychometric properties. In terms of executive function, digit span, category fluency, the DCAFs, letter number sequencing, and Stroop color word interference was used. And like I said, they used the companion study to standardize the raw scores. For depression, the Cornell score for depression was used, and this was rated by the caregiver, as well as for the functional ability, the disability assessment for dementia, DAD, was used. This was also assessed by the caregiver in the last 2 weeks. For cardiorespiratory fitness, which was the neuropsychological testing was done at week 0, middle week 13, and then at week 26. The cardiorespiratory fitness was tested at week 0 and at the end of the study. And that was done by measuring the gold standard peak VO2, the highest oxygen consumption. They did not go for the plateau and then measuring the maximum. Whatever the peak oxygen consumption was and whenever the patient wanted to terminate, that was measured. They did take into consideration the lean mass. And the second test was the 6-minute walk test for cardiorespiratory fitness. And they used the Borg dyspnea scale to assess for fatigue. And then MRIs were performed at baseline and at the end of the study, looking for hippocampal and total gray matter volume. So in terms of intervention, like I said, there were 2 arms, 150 minutes of moderate aerobic exercise. The exercise program was made in conjunction with the YMCA fitness trainers. And they wanted to standardize it because it was 16 centers all in the greater Kansas area. And the clinicians would actually go to these fitness centers to check for vitality. So there was continuous communication amongst them. So for the aerobic exercise arm, they were looking for an increase in heart rate from 40 to 55% to 60 to 75%. It was started at 60 minutes per week and gradually increased almost by 21 minutes per week. The first 6 weeks, every session was supervised, and then once it was deemed that the patient was safe, they would only supervise 1 session per week. And it was 3 to 5 sessions, depending on the patient's fitness and availability per week. In the strengthening and stretching and toning control group, they used resistance bands, modified Tai Chi, yoga, and core strengthening. And the goal was to keep your heart rate less than 100. And these exercises were switched on a weekly basis. And similar to the other group, for the weeks 1 to 6 were supervised. After that, 1 session was supervised every week. And let's see. Oh yeah, the study staff performed bi-weekly visits to YMCA. In terms of analysis, they had the linear mixed effects analysis where and they were able to correct for age, sex, and education in terms of the outcomes. For results, like I said, 248 people were screened, 76 were randomized, and 68 completed the study. And in terms of demographics and baselines, it was pretty similar. And if you look at the patient's adverse effects, they had there were 25 adverse outcomes, mostly mild to moderate, but there was 1 serious outcome where a patient had worsening of spinal stenosis and had to go for surgery. But yeah, still 25 in total. And like I said, there was a safety committee that was assessing for these adverse outcomes. In terms of adherence, almost 80% adhered to the stretching and toning group. However, 85 stuck with the aerobic exercise. I thought that was interesting. More people came for the aerobic exercise. And then in terms of the outcomes of interest, if we go to table 2, you can see that they could not find a difference in the composite memory scores or executive function, which was not what they were necessarily expecting, or in depression. And the goal of having the stretching and toning control was to compensate for the social engagement, so that any effects that would come out of physical activity or social engagement, they would be controlled. However, patients, there was an increase in the disability assessment. So patients became more functional after the aerobic exercise as compared to the stretching and toning. Also, if we look at table 3, you can see that there was a difference in the 6-minute walk outcomes. If you were doing the aerobics, you had a better score at the 6-minute walk assessment. In terms of the secondary outcomes for the fitness specific tests, the cardiorespiratory fitness showed that there was an increase in the memory scores, which was great, as well as in the bilateral hippocampal volume. So they were able to show that there was a decrease so this was shown when they collectively did the overall study, not as a difference between aerobic exercise and stretching and toning. However, when they collectively measured the cardiorespiratory fitness of the overall group, so the overall group had better memory scores and an increase in hippocampal volume. So that was great. And like I said, in terms of adverse events, one major severe event, otherwise 24. So overall discussion, this was a pilot study. They did have a small number, 76 to start with, and then eventually 68 completed it. Yet they were able to show that in terms of functional ability, aerobic exercise was better than stretching and toning. There was more attendance for the aerobic exercise as well. However, because it was all over the YMCA's 16 centers, so they were mindful that it might not be as valid, or the fidelity might not be 100% of the program. And it was kind of disappointing to not see any memory changes or executive function changes, the difference between the two. But overall, cardiorespiratory fitness, like we all know, helps us not atrophy as quickly. So they were able to show that the hippocampus did not atrophy, and in fact, there was an increase in the bilateral hippocampal volume. And so thus showing, or ascertaining that aerobic exercise is helpful. One of the interesting things that was also observed was that in terms of the exercise, patients with Alzheimer's disease did not have as much of a fitness gain, the cardiorespiratory fitness. It was 3% gain in patients in the aerobic exercise group, and then 0.03% in the stretching and toning group. The companion study, however, in the same demographics, the patients without the diagnosis of Alzheimer's disease, very mild to mild, showed more of a gain in the cardiorespiratory fitness. So there is a discussion about that, if there's the causality and a reversal of both as well. And then they said they were not able to correct for the multiple tests they were using, and there was a potential for false positives there as well. However, they said our trial was consistent with the previous work, showing that the aerobic exercise benefits the functional ability in patients with early Alzheimer's, and overall cardiorespiratory fitness will help in the improvement in memory as well as reducing the hippocampal atrophy. So that was the study.
Well, very good. I do like this also for the social. Did they talk at all about whether they thought that the socialization aspect contributed?
No, they didn't talk about that. They mentioned it just once, that the reason why they had this stretching and toning group in the YMCAs was to control for the socialization. But there was nothing was measured in terms of socialization or actually getting the patient out of the home.
Yeah. Okay.
So, yep.
All right. Well, thank you. And I don't really see any other questions, so we'll wrap up. And next week we have 2 articles. One is on citalopram and agitation and Alzheimer's, which I'm looking forward to hearing that one. And then another one on biomarkers in dementia with 2 new speakers. So stay tuned. I'll be sending out an email. We do have a couple of schedule changes coming up in the next few weeks. So I'm still sending out weekly emails with the following week's schedule. If you're not getting the emails, just send me an email at psychiatrynetwork@gmail.com, and we'll see you next week.
All right. Bye.
All right. Have a good night. Bye.